There we go. Yoo-hoo! We are live with CCO. Live with CCO, episode number 5, May 2019, with Alicia and Jennifer. Hello, ladies.
Hello.
Hello.
Hot on the heels of Healthcon 2019. They're still friends. Congratulations.
We were roommates. We were roommates at Healthcon.
And they're chatty like they're two sisters. I got to tell you before the webinar started.
Yeah, we did
I'm
good.
glad that worked out well.
That's what, is that the second or the third time we've been roommates at an event?
I don't know.
We did Washington, D.C., and didn't you go to Anaheim?
Anaheim,
See,
yep.
we were at the two regionals, and we just might, if everything works out, we'll be at New York together and in Seattle at the two regionals, because we're working on a presentation together, and got some other, her and I both have a lot of topics submitted. So if you're going to be in New York or you're going to be in Seattle during those regional conference times, make sure you sign up for our events, our lectures.
Who we got checking in on Facebook already? We've already got Puerto Rico
Whitney.
and New York checking in from YouTube.
I'm trying to see everybody.
We got Whitney.
Nice.
Ooh, there's JM Martinez, or
yep.
no,
Yeah.
it's Mary. How do you say her name? Riviera. Mara. Oh, I'm not going to do that right. Maritza. I don't think I can wrap my tongue around that. Maritza. And there's Whitney and Alexandra. And yay! There's Tiffany, our Tiffany.
Yeah. Leslie.
All those people that might be joining us, Alicia, why don't you tell us what Live with CCO is all about today?
Oh, right. Oh, hold on just a second. I just accidentally unmuted myself. I can hear myself talking to myself.
Well, at least it's not echoing here. That's a good sign.
Okay. All right. So what is CCO Live? What we decided to do, and Lorraine and I were doing this, and her sister's coming to visit, so she wasn't able to come tonight, and Jennifer was available. Yay! And it's just a way for us to have a casual interaction, kind of give a topic to launch a conversation, and you can pick our brains. Is that a good way to say it? Pick our brains?
Yeah. We got a couple questions that we prepared on how coding and billing work together, and also we're going to update you on what happened in Healthcon, behind the scenes, dirty laundry type stuff. Stay tuned.
The thing is that Jennifer has a lot of background in billing, and so she's talked at conferences before about billing with her background, and she teaches the coding and billing at a college too. But if she doesn't have the answer, she knows where to get it because she has a lot of experience in that arena. I only did 1 year of billing in a hospital, and you're not supposed to say that you don't like it, but it just wasn't my thing. And I know people that absolutely love the billing aspect, and I know people that absolutely hate the billing aspect.
Yeah.
And sometimes it's they don't care, because it really does go together. So Jennifer should tell us, because I know for a fact that this is one of the things that she talked about in lecture. What really, how do they work together? What is it about them that you need to know, both of them?
Well, they really are hand in hand. And to be a good coder, I mean, we all learned ICD-10, we all learned CPT, HCPCS, we all know what each of those stand for. But what happens once you enter it all? And that's the other side of the equation. That's billing. So once you've redacted, you've extracted the information off that note, or you've just done, the physician's told you what they're going to bill for that visit, once it's been entered, then what goes on from there? And that's the billing side. So billing is comparing all that information, making sure it's all valid, making sure that that ICD-10 code can go with that CPT code for that particular insurance carrier, making sure the modifiers are there, or it's not in a global package. So there's a lot of things on the back end that you learn with billing that aren't even taught with the CPT or, with the CPC exam. So there's a lot of other components that are very important for coding in order to get that claim exact the way it needs to be for the services that were rendered. But then on the back end, so what if it doesn't get paid? You have to appeal it. And so I started out as a coder, of course, and then they started having me do a lot more administrative duties and billing duties and aging, and I've even been a practice administrator as well. So just kind of the whole other side of and yeah, I love that side of it. So you got those people that love those codes and they love looking up and they love, I have a girlfriend who loves cardiology. We talk about, Alicia loves inpatient. Those are just, yeah, sometimes not my cup of tea, but I like teaching it. But actually my job to perform, I love the billing. I love the argument, the investigation, the making sure that the doctor is getting what they need to get paid. So
that brings up a good point that part of coding is being a researcher and billing, right? That you do a lot of research in your career. You never stop researching, because in billing you have to research, well, what was the issue? Why did it not get paid? Did something change? Yeah, I remember when a few years back, it's probably been more than that now, when they changed the injections and changed that all up. And one of my friends who does a lot of billing, and she said, you're just so used to doing the same thing all the time that you've practically got this stuff memorized. And then, like that first month, she got all these, denials and stuff. She goes, what's going on? We never get these denied. And then what had happened is they had made changes, and she's usually on top of everything and didn't catch that. And so again, if you like doing research, if you like doing the investigating part, if you like, it's never boring, I guess, in billing.
No.
I think that, again, my viewpoint is that it's all about denials, and it's not about denials. It's so much bigger than that. But it's not instant gratification with billing. Not that really coding is either, is it? But it's like you send something off and then it comes back, and you send something off and it comes back, but that is I think it's people's perspective too. Billing can be a lot of fun if you like doing that investigative work. It is a little bit repetitious, right? And that, especially if you're doing the scenarios, especially if you're doing like anesthesiology or radiology. And you work for spinal, right?
Orthopedic,
orthopedic spine. So what you're seeing, and the modifiers and procedures, and you practically have memorized what the providers are going to do because you've been doing it so long. And so that there's comfort in that, being an expert. But I guess I just didn't give it enough time. I don't know.
Well, and like we said, it's not for everybody. So there are people that don't like to sit on hold for 25 minutes waiting for the insurance company. There's but yet I look at that as, well, there's 25 minutes. Now I'm looking up more stuff while I'm on hold.
Yeah, I have time to do other things.
I'll wait 25 minutes just so I can argue with that person that I'm right.
Well,
and that I did bill it right.
When I did learn when I was doing the billing, because the billing office that I was in the hospital, they had us all divided up in different providers. So I did Medicaid, and we had 3 different Medicaids at the time, and I had 2 of them. Another girl took one, and then I had one of the commercial insurances, which I can't remember. And so I just remember it wasn't Blue Cross Blue Shield, and because somebody else had all the Blue Cross Blue Shields. And so that's the way they had us divided up. And again, I like finding out the answer, but I found that in that short time of a year that I was there, that I had people come to me to ask questions because I had found the answer, because I was willing to wait and talk I just, and they gave me their phone number. So if I had a question again, I could just call that person. I may still have to wait, but I was like, hey, remember the other day when we talked, can you send me an email because I need to verify da 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 da, and oh sure, and you build up relationships with these payers, and again, if you're willing to wait, you get the answers, and they're willing to work with you. But again, maybe I didn't give it enough time. Whitney said that she, let's see, she's on. She said help working in billing before she did coding made her a better coder. I agree. Now, I really say that I don't like billing, but I would never trade that time that I was actively doing billing, because I learned a lot during that time. And as soon as I was able to do something else, I did. But I wouldn't trade that for anything. That really helped me.
Yeah, I think it can reduce errors, and definitely you become much more cognizant of what you're putting on that claim then. And then you start to go, oh wait, this is Medicare. Oh, somebody messed up, they can't have a consult. If you get somebody who's just repetitiously repeating codes all day long, they're not even paying any attention to that. And the doctors and the providers don't pay any attention to the insurance carrier. But then when you start going, oh wait, medical assistance wants this on 2 lines, because that biller's told me I've got to redo that claim 5 times now. So wait, now I know that this is what they want, and or a particular modifier, HCPCS modifier or something like that. This carrier wants the right and left, not a 50 or something. So yeah, definitely having that background, you can now just start. It makes sense. It does require an attention to detail. You really have to have an attention to detail. And some people don't have an attention to detail.
I don't.
They just, they just.
But I don't. Now, I can abstract. You know what I mean? I can pull things out, but being meticulous, no, my brain snaps too much. Patty says, I love the coding more than the billing. So she's in my camp. But I see some other people that said they love both. Sharon says, I just passed my certification exam. Yay. Which certification was it? Was it the billing coding?
Yeah.
Let us know, Sharon. And
I was trying to get to Whitney's question here too. So yeah.
Oh, Whitney had one? No, let's see.
Yeah, about modifier 27.
While you're looking at that one.
Yeah.
Okay, and while you're doing that, Michelle made a statement, says, I work as denials resolution specialist for Medicare. How can this help me transition into coding? Because I have been told this is indirect coding. Well, you're going to be surprised. It's wonderful having had that experience. But let Jennifer answer her question, then I got some 2 cents for you, Michelle.
I'm trying to answer Whitney's. She wanted to know about modifier 27, and that's why I was looking at going, modifier 27, huh? Well, because modifier 27 is something I've never used, because it's reporting multiple outpatient hospital E&M services on the same date, and that's something I have never encountered in my experience with orthopedics and family practice, is because we wouldn't have multiple E&Ms on the same date in a hospital for any of our providers. I mean, they might have been one of those people seeing an E&M in the hospital that day, but so it's created exclusively for hospital outpatients. Physician practices don't use this modifier. So this modifier is reported on the UB04. So for your hospital services. If a patient comes back the second time and is admitted as inpatient, if they have multiple E&M services, then you would use that modifier 27 on the same day for the same revenue center. So
Alicia, the question is a couple slides down. I just pasted it there if you want to go ahead.
Okay. All right.
in the slide deck. Slide deck.
Oh, sorry. Hold on.
Oh, you got to refresh.
Nope.
Okay, maybe it's not updating.
Okay, I can.
Yep.
Let me just get out of here and I can do that, and I bet it refreshes. Not a problem. There, he's got it right there.
Any other thoughts on that one?
Okay.
If a patient comes back the second time and is admitted as inpatient, well, you do have more than one E&M, but I don't think you're going to use a modifier 27 because it depends if you're being admitted for the same thing, right? Why are you being, you got to be really careful. So if a person is, if they're in the hospital and they're discharged, right? Is that what the scenario is? And they turn around and are readmitted
on the same day.
later that day
Yeah.
for a complication or something like that, then yeah, you need to be able to explain why they're doing another E&M. But whenever you're dealing with things like complications, remember that when you're doing inpatient, you're not basing off the E&M, you're basing off the diagnosis, okay? But if this is outpatient, so if you're doing an outpatient procedure, is that what we're doing here? So they go in, they have a colonoscopy, they go home, and they come back and they end up, because they have bleeding or hemorrhaging, and they have to go in and look at, do another colonoscopy. Is that the scenario?
Now,
Or
modifier 27 is an E&M modifier. So it's only be used on an E&M service. And actually, Medicare says you're going to append this to an ophthalmological E&M. I don't know, in the hospital type A emergency department visits.
Okay.
And critical care. So if you're doing any of those services multiple on the same day, you're going to put a 27 on it.
Okay. So ophthalmology, if you have an ophthalmologist and they go in and they do cataract surgery, right? And then you leave and you come back, or they're going to do on one eye, they're going to do cataract surgery and evaluate and manage that, or or process, and then later they're also going to do something else with the other eye, because they very seldom will do something with both eyes on the same time, because if anything messes up, they want you to have one eye to be able to see. Right. So but still, so I can see scenarios happening with ophthalmology, but again, there has to be a specific reason why you would do two E&M services. I guess I just really have to have a scenario to be able to bounce it off of, if you can think of something.
Well, Medicare says multiple emergency room visits. So if you came into the ER, you left the ER for some reason, you came back to the ER, then you would use a modifier 27 on your E&M ER code. So
yeah. And that, I can think of a lot of scenarios with the emergency room where you would come back, where and they do that with OB a lot. The mother will come in and they'll not go ahead, they won't go ahead and admit them for observation to OB, but they'll take them in, and the OB consult will come down and look at them and say, yeah, you can go home. And then later that evening, their water breaks, boom, they're back in, or they're having cramps. It happens with miscarriages a lot. They'll come in and say, yeah, you're gonna, you're miscarrying, and that we're not going to admit you. Everything should come out okay. So they send you home, but then you start hemorrhaging, and then you come back. I've seen that happen before. People that had a fracture and they cast it, and then because you're supposed to see the orthopedist the next day, and then you come back later because it's swelling. The swelling starts up, and your fingers are turning blue and whatever. So you're back in again, and they have to remove the cast. And they don't, nowadays they don't cast if they're going to send you to an orthopedist.
They do a half cast.
Yeah. But back in the day, like where we were at, they didn't you didn't have an orthopedist in the town, you didn't have an orthopedist. So they would go ahead and do the work, they've just cashed you, it wasn't, but now that you have an
She said
orthopedist.
the scenario was that the patient came to the ER in the morning with weakness and then came back the same day with weakness again. And this time they were admitted as inpatient for the weakness. So they had the same complaint both times.
Complaint twice. I see that. Yeah, then you could put the 27 on there.
For Medicare. Yeah.
Medicare.
I'll
Kathy
let you
says
guys manage the questions because I'm not sure which ones take a long time to answer, put it that way.
Okay. Okay.
So
Let's
yeah,
see. Okay, you
look
put
at the
this one up.
comments.
Let's see.
Yeah, I got a
work
couple in there.
as denial resolution special Medicare. How can this help me transition to coding? Because I've been told this is indirect coding. It actually, you're dealing with the codes, you're seeing the codes, you're familiar with them. Now you don't have a wide spectrum. It's pretty niche, right? Of what you're seeing. However, it gives you a unique perspective of what Medicare wants. And quite honestly, whatever Medicare does, everybody else eventually follows suit. Not always, but eventually. And especially now that risk adjustment is such a big deal. But what I would say is go get your certification, your CPC. And if you already work in this area as a resolution specialist, it'd be very easy to transition after you're certified into another area. There's always a need for that.
I personally think that gives you such a unique quality as well, because you have that inside training inside, you can understand what their somebody on the payer side. I mean, I would love to work for a payer or study with somebody with a payer, just because I want to see what they go through. I want to see what they do as to why they send it back to me. I don't mean to be mean when I talk about payers, but we have our job and you guys have your job, and they don't always meet with each other.
So if this is Michelle's question, she goes, I already do have my CPC. I would just start looking for positions now, whoever you're working for now. But yeah, you can use this as experience in your resume. If this is,
and that would either get you as a coder or a biller in any office, would be my opinion. Even though you're not credentialed as a biller, it's still, you have that knowledge now of
right.
the
You don't have to have you don't have to have the billing credential to be a biller, but it definitely gets you in the door if you if you do, or if you have a coding credential, because they know you understand. But just the word Medicare and having worked with Medicare claims makes you a desirable candidate for anything, because Medicare scares people. And it's really kind of straightforward, because they either do or they don't. They want things done their own way. But like I said, everybody else is pretty much compliant as to what they do. So if you can do Medicare and take care of the denials, then yeah, you're several steps ahead of somebody that just walks in the door as a coder. And
it would also help training the coding staff too.
Oh my gosh, yeah.
Oh yeah, to go, oh gosh, you guys, what are you doing here? No. Let's revamp this process. We gotta go.
Yeah.
Yeah.
Oh, this is a good one for you. They're asking, let me get the next slide up, to explain what a UB04 form is.
Oh, lovely. So there are 2 insurance claim forms that are submitted to carriers. So the services that are rendered inpatient in a hospital are what are submitted on what we call a UB04 form. And that form, or it's also called a CMS 1450. I don't want to get you confused though. Typically it's used UB04. That claim form is going to include all of the services that were given to that patient. Everything that was done to them is going to be submitted on that claim form. And remember, with coding, we need to have our principal diagnosis and things like that. Right. So it's got all the information of while they were inpatient. Now, the CMS 1500 form is what providers and outpatient facilities will use. So even though you were at the hospital, my orthopedic doctor came and saw you. his charges are going to go under CMS 1500 because he's a physician separate from the hospital providing services. But all the internist, your radiologist, anybody who was at the hospital who happened to do something for you while you were there at your stay is going to bill under a UB04. So there's 2 separate claims forms that are used to submit for charges for payment reimbursement to the insurance carriers. So there's provider side, outpatient, and then there's inpatient, and inpatient's UB04.
So I just brought this up. This is what a UB04 form looks like, and just Google
a
image it. It's not
lot of information.
Yeah. So the thing of it is look how many lines. I know I don't want to click
like
on one and open it up.
72 or 79 or 90 or I don't know, a whole lot of lines.
But a CMS 1500 is completely different.
Is
in that it only has
33 lines, yeah.
Yeah. And I mean, you can only put in like 4 diagnosis codes. You know, see,
up to
can
12.
you see how small that? Okay, see, there's just all this information here. You don't get much space. So, but you have to remember that things with billing for inpatient, the UB04 form is that it's based off diagnoses. So if you have a diagnosis of a patient that has a diabetic PVD and an ulcer, a foot ulcer and gangrene, and they're going to have an amputation, well, they get paid, the hospital gets paid like $50,000, and then they have to use, that's all, it doesn't matter if it costs them 60 to do the job, they only get $50,000. But all of that, that's why that form has all the lists. So then any other comorbidities have to be listed on there and stuff, and then it's tracked, the use of it, whereas the 1500 form, it's all about the CPT codes, and then you have the ICE to back those up. So if you understand how they do what they do, the forms make a lot of sense. I work billing for Blue Cross Blue Shield. What should I be looking for when working potential claims? Is there any reference or resources you can give me to make working with and pinpointing errors without always having to call? That's a good Jennifer question, because I just find that incredibly annoying.
I work billing for Blue Cross Blue Shield. You work at Blue Cross Blue Shield, or in your office you handle all the Blue Cross Blue Shield claims? I guess I need a little bit of clarification from that if you can.
I'll look
if you work just the Blue Cross Blue Shield claims in your office, if that's what the question is pertaining to, is there any references or resources to pinpoint the errors? The provider manual is going to be your first one. And we actually, I like the provider manual for Care First for our area. Our area is carefirst.com, or for Blue Cross Blue Shield of Maryland, DC area. Theirs is very helpful, their provider manual. Now, not every provider manual is going to be as specific as definitely Medicare's. Medicare's is lovely. Every answer you ever want to find is in their internet manual. But Blue Cross Blue Shield, you definitely would want to have your manual and ask to see your contract as well. So the administrators have all those contracts, and they have to be renewed every couple of years, so they keep up on them. But ask to see the verbiage in the contract, because you may have specific wording in your contract about things like timely filing, which providers can bill for services, what type of providers they have you listed as. See, we're an orthopedic. So one of the plans in Care First in our area allows us to take x-rays in our office. So some of the particular plans of Blue Cross, you have to go to a facility to have an x-ray taken. But because we're orthopedic, they allow us to take certain x-rays in our office. However, one of our doctors is a DO. So they may get people coming in for pain management that they're doing with them, but they can't take they can take an x-ray. They're not going to get paid for it because they're not an orthopedic provider. Even though they work in an orthopedics office, they're not covered under that contract to receive payment for those services. So those are things listed in our contract that, you know, we'd had to figure out, and it's actually in the provider manual as well. But the contract would be another good place to look. And there are a couple websites out there that tell you all of the remit and remark error codes. Just Google remark codes and you'd find the website right away. It's like Washington Publishing or something like that. They are going to list every code as well, because sometimes maybe you don't have the last sheet of the EOB if you scan things in or something like that, and you're not able to tell what exactly they mean by this denial code. And in general, knowing how they like things. Blue Cross Blue Shield of Virginia liked the F and T modifiers for fingers and toes, but Blue Cross Blue Shield Maryland doesn't. So it's just, you know, knowing how, once you know a particular carrier, what they like, then you can, you know, help train the rest of the coders to say, oh, wait a minute, Bill, use this instead. So
yeah. I really like what you said about having that manual, but I had forgot about the contracts. So many people don't think about that because in their office, it's not talked about. The supervisor or whoever handles that. But if you're in a smaller practice or you're the biller, you surprisingly may not realize what the contract stated. And even some providers don't really pay that much attention. They just redo the contract. And unfortunately, this really plays a big part into understanding the compliance as well. Don't you think that if you have a better understanding of the compliance aspects of an office, then because it's not all about fraud and abuse, it's some of these other things that you may not even be aware of that are behind the scenes, it'll help you with this billing. But the contract, how often do they redo the contracts?
Typically every 3 years.
Yeah, I was gonna say, I know it's not every year.
No, it's typically every 3, depending upon the carriers mainly. But, you know, in some things, you want it to spell out in your contract.
That's right.
Because it may default to your state requirements, which in the state of Maryland, I think we have a 60-day timely filing or 90, one of the two, but it's a very short amount of time. So by the time you get a claim back and go, wow, they haven't paid this claim in a while, let me check on it. It could be at least 45 to 60 days before you find out that that claim is kind of lost in space somewhere. And if you have a 60-day timely filing, you got to be on top of those things, like checking every website, make sure that they don't have the claim somehow. But if it's specified in your contract that you want 90 or 180 days, then you can supersede your state requirements. So they might default to your state requirements. So you'd want to make sure that, you know, especially timely filing, that could be, think of a surgery or something, that's lost money.
That's lost revenue, like, that just slips through your fingers. And so I think if you're going to be maybe a biller in an office that was struggling or having trouble, that is something that you may mention that you want to look at. When was the last time they did their contract, and you know, can you look at it to make sure that you understand things like that, timely filing? But there's so much more to it than that. And usually billers wear so many more hats than coders. Now, sometimes you have a coder that's the coding and the billing is together and you're wearing the same hat, you know, so you have to know it all. But you may be the person that's the billing expert in your office, and then you have the coders, and you're not just filing claims. It's so much more than that. You know, whether you want to get the credential or not for billing, but if billing is something that you're interested in, surprisingly, I'm surprised, but billers tend to make on the salary surveys more money than coders, and they get jobs faster. You can get a job faster as a biller than you can as a coder a lot of times. You know, so that's something to consider. Consider just going and taking a course anyway, like CCO offers a course in billing. Whether you set for the credential or not, it's the fact that it's beneficial to you to understand that background stuff. Or looking to see what textbook. We were just talking before that the textbook that we use at CCO, the college that Jennifer teaches at, the billing course, we use the same textbook, and it can be bought on Amazon. So that may be something that will give you a launching point. Just increase your knowledge base. Let's see. Let me look and see what the next question is. I've been coding bilateral procedures at my job with Modifier 50 for several months instead of RT and LT. All of a sudden, they said insurances are denying the 50, and we can go to the, okay. Yeah, well, this is all up to them. They have every right to say what they want, and they can change their mind as much as they want. So, Jennifer can tell you more about how often it happens, but there's not much to say. Is if you want to get paid, you do what they want.
Unfortunately, and then you'll find 6 months later they'll jump back again. Either their system isn't processing them properly or something like that, and then they'll go back again. Because I remember for the longest time, TRICARE, you had to do right left. Medicare, you have to do right left, but medical assistance, we have to do 50. So I mean, and knowing which carrier it is always the trouble, because and it's actually pretty interesting. But MGMA, the Medical Group Management Association, they're the only ones that have established a benchmark for what it costs to appeal one charge is $25 at least. So you're looking at that person's time, the paper, the appeal, somebody at the other end's got to process it, and you think that I'm appealing a charge that I'm going to get paid $7, but it's costing $25. So it's really important to get it precise the first time, but unfortunately you know that's where you're going to run into some of these problems. So you go, well, we always did 50. Well, now they want right left. And I bet that carrier put out some kind of notice at some point in time, and we skip over them. So most of the carriers on the first of the month, so subscribe to all the listservs with the insurance carriers is another great tip. Medicare sends like 3 a day, I think. You know, Cigna, Aetna, Blues, United Healthcare, they do it like at the beginning of every month, that they're going to make changes, and they notify you typically 90 days in advance. So a lot of times they might have said something, or it's posted on their website perhaps, or but we're so busy with our jobs, we don't read that email. Oh, I'll look at it later, and then 3 months have gone by, and then you go, why are they doing this? And then you go back and pull up your emails and go, oh, they told me that they were going to do that.
and honestly, you don't get paid to look at that stuff, right? You just have, you're supposed to know it for your job. I mean, so it's like getting up every morning. Remember when people used to get up every morning and read the news in the paper? And, it's one thing to do local news, but then if you a bigger paper that you would get, you know what's happening, and that you just have to commit to doing that and staying on top of it.
And, when you get these emails, they're sending you everything under the sun. So you're just looking for dermatology and go, oh, okay, anything new in dermatology this month? No. Okay, then it doesn't affect me at all. So,
Now, another thing to consider, I thought when Jennifer was saying this too, is that not all, for people who are not in billing, not all providers take all of the insurances, so whatever your office takes, if you're working for a general practitioner, they may take Blue Cross Blue Shield, but they may not have a contract with somebody else, and again, you don't have to know every single insurance out there. But they usually take a lot of them. Let's see. Can you ladies please give the benefits of having the CPB? Well, Jennifer's got it. I'm too scared to sit for it. I'm afraid I might pass it.
And then they're going to go, Alicia, you're a CPB. Answer this question.
And again, it's not, I don't want you guys to think, I try never to say anything negative, so I joke about it. But, we all have things that we like most. So if you ask me what I like the most, I'll always tell you it's ICD-10 and the disease process and PCS. Okay. And I know Jennifer really likes the billing. And so whenever anything comes up, I just, that's why it's really good to network. He's like, Jennifer will know the answer to that question. I don't have to use my brain cells. I could look it up and find it, but I don't want to. So yeah, tell them about that credential and how you tested and stuff.
I actually, when I saw it out there, I actually took 2 at the same time. I took the instructor and this one. I loved it. It's one of those, okay, Alicia knows me, anybody else might know, I'm a huge Star Wars fan. So it's like, to me, it was like reading a new Star Wars book. It was just exciting. And it was one of those that I really got interested in. And I thought it was very well put together. That book that we talk about, Understanding Health Insurance, somebody asked what's the name of it. That is very well put together as well. It just flows. All the information works wonderfully. I enjoyed doing all of the webinar videos for the CP, for the education that we do. And it just gets me excited. So you learn pretty much everything. You learn about the carriers. You learn the differences of the carriers. You learn about that very important CMS 1500 form, which is about 50% of the examination for the CPD. So you really need to know that form. It's very, very insightful, actually, just to kind of learn a little bit more information. I forget, I've been doing this for so long, I forget. We did a webinar with the last monthly one in April, and somebody, I think it was that, and somebody asked a question saying, well, what's the global package? And I was like, you don't know what a global package is? But I get so used to that, something I've done every day, and I was like, oh, okay, well, and it's just something that's not gone over sometimes, and it depends on the credential you have or your training. So yeah, it is just like, oh, so it gave so much information, and it really, it just brings, coding's just this, it brings the whole spectrum together. So yeah.
When I taught that same book, when I taught at college, and this was many moons ago, and I would make my students fill out 100 1500 CMS 1500 forms, because the textbook has all of these practices that are, and so they would literally have all the information that they had to put in, and they had to literally type it all out, and you have to do it in caps, and you can't use the enter key, you have to use the tab key. There's all these little things back then that you had to do, and I made them do 100 because they needed to know how to fill those out. Now data entry, I don't mind. I can do that all day long. But it's all that other brain stuff that so it's really, really important to understand those.
I was kind of excited because just today I've this book, using this book, I'm actually just was picked up as a full-time faculty member at the college. So we met to discuss compiling this class, and based off of this book. And I went into the publisher's site, and they have this like whole demographic sheet, and you go in and you enter that. And I was like, wow, this is really cool. I didn't have any of that when I learned this is CPB stuff, but it's really interesting. Yeah.
If they still have that, this was a program that you could get alongside the text where they could input all this data and stuff. And then what would happen is they would have to print that out, and I would take a highlight marker, and if I saw a mistake, I would highlight and make them go do it again.
Well, but that's the CPB is they put it on there, they fill out a form for you, and then on one sheet they tell you why the person came in and all this stuff, and then they give you the form, and you're like, and then they say A is number 1, 2, 3, 4 are wrong, B is 5, 6, 7, 8 are wrong, and you got to look at it. You got to know, because if one little tiny thing is wrong, that's the answer to your question, and it could be some little check mark, it could be, and it's something you may not even pop out at you. They might have transposed the date of birth, and maybe that didn't even pop out at you or something. And yeah, So
Because it
yeah,
will get
that
denied and
practice
thrown
is
back if you put in the wrong date of birth. And you're thinking, what? After I got all this up to yeah. So it is a good credential. Like I said, if you go look at the AAPC's website on income, CPBs make about $10,000 more a year than CPCs, which I was shocked. But you know, and it's pretty easy to get in and start in billing, which I think is brilliant. Because again, like Jennifer said before, it lets you see both sides of both worlds. And being a biller makes you a better coder. Being a coder makes you a better biller. I work for an independent lab. We are getting denials for this particular code, which is a HCPCS code. Okay, using point of service 11. They collected the specimen. I was looking at the ACP form, and one of the answers said that you could not code 80307. This, I don't know if, can you answer that quickly without looking it up, or is it something that you're going to need to do a little investigating on?
Yeah, the G0483. I might be able to find it real quick. Let me.
Because we only have about 15 minutes left in our thing. So if you want to look at that, I'll look at the next, and we'll come back to it. Okay.
Sure. Yeah. Yep.
Okay. Let's see if I can do that. I started working accounts receivables. What should I know? Absolutely no. Well, I can help with a little bit of that, even though Jennifer is the expert while she's looking up the HCPCS code. One of the things that's really important about accounts receivables is that, okay, you have denials and you have receivables. Think of basic accounting, or think about doing your checkbook. I guess if you dummy it down to the lowest level, and I don't mean to say dummy it down, but the basic level. So you have the money coming in, and this money will be coming in from the payers, which could be Medicare, Medicaid, insurance, but it could also be individual people paying their bills, right? So when you're in charge of the receivables aspect, you're trying to match up what's been billed with the money that came in. And for some of you that may not realize how money comes in from an insurance provider, it doesn't just come in like a check for each account that you build. It comes out in one big lump sum for a specific amount of time. Okay. Now, the accounts are listed there. So if you've got, John Smith and Betty, Sue, Bob, and you got like 15 people that carried Blue Cross Blue Shield of whatever state you're in, and this is the receivable. This is the check that you're receiving for all of those people. So it could be a $30,000 check, and you are in charge of matching up that if Billy, Bob, Sue, or whoever I said, they you billed them $395 and they paid $395 for that encounter, because they may have 4 encounters, and this is just one of the 4 encounters that amount got paid. You have to match all this stuff up, and I always like to think of it as you're matching up your checkbook, and some people don't use checkbooks like they used to, but you literally have to make all of the pieces match. So again, let's say John Smith has 4 encounters that are being paid, and the total for the 4 encounters is $5,000, but this encounter was $395. This was $1,268. This was, and these are odd numbers, okay? And then that has the date, it has the ID number and all this other stuff. So you got a check with 15 people on it, and 2 of those payments were this one and this one. Okay, because they don't always pay them consecutively. You have to match all of that up, and then you click that it's paid, right? And that there's a remaining balance of, and then what happens if, again, if a denial comes in. So the receivable people usually are, depending on where you work, but they see all of that stuff, and then that shoots out to the denial people that are going to go and see what happened. But you're in charge of making sure everything matches up, and that all 4 of those encounters got reimbursed. And like they said, this one and this one got reimbursed in this check. This one gets reimbursed. And then, 3 months later, you're still waiting for this one and you haven't got it yet. So then then either you follow up or you figure out how come it's not being paid. And everything has to match up. This is where that attention to detail really pays. When you're doing denials and stuff, you're told what you're being denied for. So then you go and you investigate it and you look at it and you say, okay, yeah, I can fix this, or yeah, we didn't use the right modifier. We're going to resubmit, da, 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 da. But when you're doing receivables, to me, that's even more complex because that's detail. And we're talking about this guy just having 4. But what if it is something to do with a diabetic foot ulcer and that person's coming in twice a week for 3 weeks? All right. That isn't all lumped into one. No, that's every single time they're seen. So you got, you could have 30 for just this one guy, and one of them might be $24, and one may be $5,000. And then with receivables, then you're going to be working with, okay, we still haven't got paid for this $24. And like Jennifer said, it costs $25 to go and investigate it and see what it, are we going to write this off? If we write this off, then that goes into another department and you have to communicate with them and say, okay, we got paid out of the, we billed out $5,000 and we got paid $490, but we didn't get paid this. So we're just going to write that off. We're not going to keep spending money to get that last amount left, and stuff like that. So if that helps you in what receivables does, usually a biller, if you're the only biller in the office, then you're doing all of it. But if you're working for a facility or a bigger office, like a large practice or stuff, you'll have people that, like I said, they divided us up for insurances and stuff. And so you may do all of Medicaid, and you may do all of Medicare, and you may do all of Blue Cross Blue Shields, and you do all of Aetna, and you may do receivables and billables. Or you have one person that does all the receivables and this person does all of the billables, and then another person does all the denials. And then you have a supervisor that, so it really depends where you work. Attention to detail is what I would say.
Yeah, one of the factors of working the AR, it depends on the type of business that you are. When we talk about things like neurology, OBGYN, cardiology, orthopedics, you start getting some high dollar claims there.
Yeah.
If you're a family practice, the main thing you might want to be worried about in a family practice is making sure you're getting reimbursed for those vaccines, because that's a big expense out of your pocket ahead of time, because you have to purchase all the vaccines. So you want to make sure you're getting paid for them all on the back end. So that might be something you'd want to work first, is you might want to separate your AR report by codes and maybe try and get payment for those first. Or if you're like a surgical practice, you work all the high dollar ones first versus something that's out 120 days. You want to work that 90-day $5,000 claim versus before you work 120-day $150 office visit claim. So it depends on the type of practice you are, and it depends on how many people you have in there. Maybe you're the only one who does every high dollar claim. You handle all the surgeries, somebody else handles all the daily office routine stuff. So but figuring out what your practice would like to have you do first is a good say, hey, there's a lot of high dollar claims out here. Do you want me to work all these first and then I'll work on the other stuff? Because the high dollar claims could actually take a little bit longer because you may have to do more research, more phone calls, write an appeal letter, have the doctor dictate a letter of medical necessity for a group of codes perhaps or something. So send medical records. So
that's like I said, billing has a lot more hats in it than coding does.
Yeah. I'm still working on that lab.
Oh, okay. And I'm going to go look at this other one.
Yeah.
Come on, guys, give me one that I know. But then I guess we're talking about billing. So it did say coding and billing. No. Do you know the reason why an account shows up as on 91?
I can do this one quickly. I saw it in
Okay.
there. It's a fluke. It happens to everybody. I don't know why. You know, that bothers me too. Sometimes I'll go, okay, I just worked this report 30 days ago. How come this person wasn't on here and now they're on here at 120? Where did it come from? Where did it go? And I don't know how it does things. Sometimes it happens. Maybe if it happened to have been 32 days, maybe it jumped it from one bucket to another bucket. That's what, you know, we call them. So just, you know, yeah, that does happen, and it is very frustrating that all of a sudden this claim will pop up there and you're like, I know it wasn't there before, so how did it get here now? And it's good to know it happens to everybody and not just me.
Now you've learned some really, really good billing terms like bucket, and I really use those terms.
Somebody will look at you and go, what are you talking about, a bucket? We don't have any buckets. What are you?
Oh, this is fun. Let's see. I'm going to look over here. Cynthia says, definitely. Okay, you're answering those questions really fast for him. Good. So she's still researching that one. If we can't find it, we got about 6 minutes. Then
what's our Q&A next week or the week after?
Yeah, we could definitely put this on there if you'd like. We can do that.
Because I've run across a couple guidelines, but nothing exactly what I need to answer the question. So
okay, so this is what you can do. A couple things. One, if and I'm not sure who submitted this question, but if you're in the CCO club, submit it there. Okay, because then everybody's going to be able to see it at once when Jennifer puts the comment in the forum. But even though it's there, we can use this as well. And the Thursday, the second to the last Thursday of the month, we do our large Q&A webinar, and it's questions just like this, the real practical questions that people are looking for us to answer, and they take a little bit more investigating and time, but it's something that you can have in front of you that you can turn around and show somebody else and say, oh, by the way, we got this answer, this is why. This is, you know, these are resources that we can use. We don't, at CCO, we try to help you learn how to do those searching and investigations and stuff like that. So I always want to tell somebody when they ask a question, it's like, did you Google it? Because you know that's what I'm going to do, right? It's like, how do
we know where to Google it?
That's right. I was like, that's why I did that. The student webinar the other night. I was, you know, I said, there's certain places certain things that you can put in Google to know that you're going to get a reputable place to look versus just putting in, you know, oblique fracture. You know, no, that's not going to get it. So again, there's little tips to help you with that. We've got YouTube videos for that. So if you want to go to the YouTube channel and look at some videos on tips on how to do research, that's in there. Let's see, anything else that's
I didn't know if we had any more questions. We said we might discuss Healthcon. I had something that just popped in my head.
Yeah, let's discuss Healthcon on the way out.
Something that was brought up at one of the general sessions by Bevan Erickson, he's the president of AAPC, is that they were looking at doing a CPC online. I'm curious, has anybody thought about that? Would they, you know, do they want to do the CPC online like AHIMA does theirs online? Or do we like our books, and do we like the old-fashioned paper and pen and format? I'm curious.
That would be good feedback to get. You can put your comments here, but you can also put your comments in the club. It would be interesting to see what you guys think about that. There's definitely pros and cons to both ways of doing it. They talk about it every year, and so far they haven't. Winnie says she thinks it would be faster doing it online.
Well, and then two people said they like books.
You'd still have, like AHIMA, you still take your books in. Okay, the books aren't going to go away. They're not going to give you an encoder because you're not going to have 2 screens to test. So it's not a matter of the books, but it is a matter of, you know, you can get instant feedback. But anyway, I'm curious. Well, so you mentioned something about Healthcon. I wanted to mention something about Healthcon too, that if you get a chance to go to one of the conferences, and not just the AAPC's conference, I'm talking about a conference. AMBA has a great conference. PACOM has a great conference. AHIMA, all of them have really good conferences. I've gone to several of the different ones, and so has Jennifer. But if you ever get a chance to do that, I think that you should try, because it is usually a large investment into your pocketbook, but the networking and the ability to meet people that have experience that you didn't, or genres of what you do, not just coding and billing. There was one person that was a fraud investigator, and one lady, tell them about the lady that is the coder from Saudi Arabia. It was the AU, is it the AUF? Arab Emirates, or
United UAE. United
UAE.
United Arabic Emirates, Arab Emirates. She was just a fascinating person, and the reason, she's from India, and her and her husband and family, they moved to Saudi Arabia area. I don't know exactly which country, and she was the only CPCI in that area, and so they hired her, and she's now goes around to all these countries in the area, and they're implementing programs over there, not to offshore US jobs.
No.
They have their own hospitals that they need coders for in their own hospitals. I mean, they have Johns Hopkins over there. They have Columbia. These major universities have hospital systems in these other countries, and they need people within those countries to code their own claims for them. So
they don't use ICD-10 CM. They use ICD-10, whatever, like Canada's CA, Finland's FN, and they have their own. So wow, it was really cool. I only got to meet her for just a few minutes, but Jennifer got to talk to her a couple times.
She is just very interesting. She speaks like 5 languages, and she's just a very people who can do that are just, I find, fascinating. I just barely write English very well, so.
I know what my mother and I used to say, like, you want to learn another language, you can't speak English. So what that tells me too, that I can convey, or we can convey to you, is that there is so many things you can do as a medical biller and a coder. You already, after tonight, now you know that billing is divided up and multifaceted, all kinds of hats that you can wear and everything. It's that way with coding as well. And you can have a niche that, like I have a niche that I really, really like, but it's always changing. So many other things that you can do. And maybe you want to travel, right? Maybe you want to go overseas and see how they do it. That's one of my long-term goals, is to go over and see how they use ICD-10 in other countries and what we can learn from them. What they do, they've been doing a lot longer than we have, so we can learn from them, and then also turn around and share what really works for us. So someday I'll get to do that. I have a passport now, so I should be able to do that. Again, thank you guys for joining us. We'll wrap it up. I see this, I'm not sure, hold on, where this is popping up from. Oh, somebody sent me some other post. That's something else. So let me just put down here our last slide. We've been doing this every Wednesday evening. And again, it's just a casual way for us to kind of, Laureen says kibitz, so I don't know what that actually means, but just chat about things that are on your mind. We'll come up with a topic to kind of get us started. But if there's something that you want us to chat about, let us know. Know that you can go to the CCO, cco.us/club and put all kinds of questions in there. We have other subject matter experts besides Jennifer and I that are willing to answer your questions. We enjoy it. And then if we know if it's something that we can share with others, like I said, that great HCPCS code question, then we'll use it on one of our webinars. That's it.
Thank you for inviting me tonight.
You guys, we all saw your son's fingers creeping around the curtain. I thought he'd show his face, but he didn't. So
yeah, I was texting my daughter to come get him.
You've done that in a webinar too. your kids are not being quiet. I told my husband. Yes, we all work from home. All right. Well, thanks, guys.